Hello, everybody. My name is Herwig Gerlach. I'm professor for anesthesia and intensive care in Berlin, Germany at the Klinikum Neukölln. And in the following minutes, I want to present you a very specific problem in clinical trials. And this is planning clinical trials because very often you have the problems of interpreting biomarker studies which are done previously to a clinical trial, and I'll show you how this may happen. Here are my conflicts of interest. Actually, they don't have anything to do with the following presentation. So first of all, if you're doing biomarker studies, you always have to ask yourself, what do I want? What do we want to do with this biomarker? Do we want to have a diagnosis, for instance, infection or not infection, sepsis or not septic? Do we want to have a prognosis? The patients will survive or will not survive, or do we want to have a monitoring? And which means that you use a value to, for instance, guide your therapy. This difference is very important already before you start a trial. So let me give you a very provocative example. I want to know from you, is this a man or a woman? And if you see, how shall I know what this figure is, a man or a woman? I say, why not? We have two biomarkers of gender, the length and the weight. So why can you tell me if a person with 172 centimeters or 68 kilograms is a man or a woman? Well, the answer is quite easy. If you look at the statistics, these are old German statistics from 2009, but believe me, there's not a big difference until now. And here you see the example which I took, 170 centimeters, is exactly in the middle between the two Gaussian normalized distributions of length of women and men. And they are highly significant difference, as you can see, or as you can imagine. However, this question cannot be answered. So it's not enough to have something which is significant. And just coming now to the first example, I just put in here a 2x2 table. And let's say you have a biomarker which is declared as positive if it's above 1 and negative if it's below 1. You have 100 patients, and of these patients, 40 don't survive, 60 survive, and here you see the distribution. Well, on the first view, well, there seems to be an association. The non-survivors have more positive markers, the survivors have more negative markers. However, the first question always is this significant? And the example I showed you is extremely high significant. It's extremely high significant in a Fisher's exact test. But this is not enough. So on the second step, you have to make the evaluation to see the quality of the tests. And this is utmost important, this is done by viewing from the side of the outcome or the diagnosis. In this case, it's an outcome, non-survivors and survivors. And you see, are non-survivors those with a higher marker? These are 31. And you just compare this with the whole numbers of non-survivors. This is a so-called sensitivity. And vice versa, you look at the surviving patients. Are they negative in the biomarker? 47 divided by 60 in total. This is a specificity of the marker. Okay, so now we have an information about the sensitivity and the specificity of the biomarker. However, who tells us that 1.0 is the best threshold, the best cutoff of this biomarker? And so this has to be demonstrated, and this is usually done. And for this, I show you another example. Here you see again two rows of data for the diagnosis 0 and 1, let's say sepsis or not sepsis, this doesn't matter. And you see, obviously, the positive patients have a higher value of this unknown biomarkers, whereas the patient without the diagnosis, it's much deeper. If you just take a value here in the middle, about 109, you reach a sensitivity of 90 and 91, so very nicely. And this test, of course, if you test it with a t-test, is highly significant. If you now change the cutoff and you go scroll down and say, oh, let's take 90, maybe then we have a higher sensitivity. That's true. However, you lose specificity because you don't get those patients you increase the sensitivity, it's on the right-hand side, but you lose specificity because you go down, you lose the negative patients with a negative biomarker. And if you go further down, you finally have 100% sensitivity. You catch all the sick patients, but however, you lose all the healthy patients, so you have no specificity anymore. And the same holds true for the other side. You can increase the threshold, lose sensitivity, and increase the specificity. And finally, you can reach a specificity of 100 and lose completely the sensitivity. If you put all these possible cutoffs together and put them across each other, here you see from 77 to 143. In this direction, you lose sensitivity. In this direction, you increase specificity. And if you take 1 minus the specificity and you put this in a diagram, these are the so-called receiver operating characteristics curve. And you see if the knee of the curve is far up and far left, then this test has a good quality. We saw it with 90 and 90 specificity and sensitivity. Now here you see another example, rather a bad test. Do you see any difference between, well, okay, maybe this is a little bit higher. You see here sensitivity is 61 and specificity is 60, so it's rather than throwing a coin than to make a decision. However, this test also is highly significant. That means significance does not mean that you have a good biomarker. This is a very important message from this talk. And here you see this ROC curve again, and it's again like the line of equality. That means that you have a marker which is just like throwing a coin. Now the next question is this the physician's view? Do we really want to know if a positive patient or a non-survivor has a higher marker? No, we want to know if our marker is valid to give us a prognosis of the patient. So you look completely from the other side. And this is the validation of the marker. That means we are now looking from the marker side. And we are now looking, are the positively tested patients really not survivors or sick at whatever you take as an outcome or diagnosis? And on the other hand, you look if those with a negative test are really healthy or surviving. And this is the so-called positive predictive value or validity and the negative predictive value and or validity. And these are the key numbers which you have to keep in mind when you evaluate biomarker studies. At the example for PCT, procalcitonin, you see here the ROC curve, which I showed you. It's very nice compared with other biomarkers in this study. And as you know, there have been several trials made, and one of which is to see if this procalcitonin really is able to predict if we have bacteremia in patients with acute fever and we think we suspect that it's a bacteremia. Can PCT tell us if the patient has a bacteremia or not? And here you see also two other biomarkers, CRP and even the old erythrocyte sedimentation rate, all significant differences between the non-bacteremic and the bacteremic group, which was validated by blood cultures. However, if you look for the ROC curve, you see that CRP and ESR do not have a very, very good performance, whereas the PCT is about 0.83 with the area under the ROC curve. And this means, okay, if then it can only be the PCT. And now this is the key table which I want to show you. Here again, you see the trend. If we take a different cutoff, we can decrease the sensitivity, we can increase the specificity by increasing the cutoff. And here you see an effect on the positive predictive value. The positive predictive value doesn't even reach the 50% mark, whereas the negative predictive value stay all around 90 to 100% over this cutoff. With other words, this biomarker can tell us if there is an absence of bacteremia, not if there is a presence of bacteremia. You may say, well, I don't understand, because it's the same presence or absence. It's just the other right. That's just two sides of the same coin. No, it's not. Here you see the ROC curve, and here you see the data from the study. If you do this with the ROC curve analysis, you may get a sensitivity of 72 and 92, a specificity of 92. Looks very nice. However, and of course this is different, as I already showed you, if you want to predict something with this biomarker, you have to decrease, and here you see that it is a difference between positive and negative predictive value. All these negative patients with a low number of the biomarker are really negative. They don't have a diagnosis. So you can predict the absence. And this was very important in two large clinical studies, which I want to show you at the end. And this randomized study, the PASS trial, it was the investigators looked if an early increase in patients which are suspected to be positive in antibiotics and other treatments can improve the survival. And here is the protocol. The protocol has the principle of an alert PCT. That means if it's higher than 1, we increase the treatment. Positive predictive value. And what they did is they increased microbiology, they increased antimicrobials and even radiologic treatment and diagnostics. So they really pushed up the treatment options when PCT was higher than 1. Already we learned that this has not a very good predictive value, and you see it here. It was without any effect. And so it was concluded it's not useful to use this protocol. However, if you do the opposite and take the negative predictive value to see we put away the antibiotics if we are below 0.5, then this strategy is really increasing survival of patients. And not only this is decreasing the antibiotic consumption and the costs for treating these patients. And coming back to the first example, so it was just the wrong question and the wrong point of the wrong cutoff. If we would have asked, what's about people with lower than 155, we would have a very good negative predictive value for men. Or if we have asked, if we're higher than 185, we have a very good negative predictive value for women. So it's important to take the right question, and it's very important to learn that we have to use the predictive value. And if you're interested, here is one paper which I wrote a while ago. And thank you very much for your attendance, and have a nice Congress. Thank you.